Welcome to our video on an overview of the antidiuretic hormone ADH, renal water reabsorption, and polyuria. After watching this video, you should be able to discuss how the antidiuretic hormone ADH, also known as vasopressin, the ADH receptor, and the medullary concentration gradient work together to reabsorb water in the kidneys, the difference between aquaresis and osmotic diuresis, the difference between central versus nephrogenic diabetes insipidus, and diagnostic testing for diabetes insipidus. You should also be able to determine how water intake and/or defect in any of the factors involved in renal free water reabsorption can affect plasma osmolality and sodium concentration. The antidiuretic hormone ADH, also known as vasopressin, is a hormone with many functions, but its major function in the kidneys is to promote the reabsorption of filtered water. ADH is synthesized in the hypothalamus, stored in the posterior pituitary, then released into circulation as needed. ADH release may be stimulated by hypovolemia or hyperosmolality. Traditionally, hypovolemia and hyperosmolality-induced ADH release are considered appropriate ADH. ADH release may be stimulated by many other stimuli. When ADH release is stimulated by stimuli other than hypovolemia or hyperosmolality, it is referred to as inappropriate ADH. Common conditions that lead to inappropriate ADH release include nausea, pain, malignancies, physical stressors, and neuropsychiatric drugs such as antiepileptics, antidepressants, antipsychotics, morphine, etc. Upon release into circulation, ADH binds to different receptor types to exert its end organ effects. Binding of ADH to V1A receptors leads to vasoconstriction of vascular smooth muscle. Binding of ADH to V2 receptors on the basolateral side of collecting ducts increases the expression of water channels aquaporin 2 on the luminal side to allow for luminal water reabsorption. Here we have a collecting tubule passing through the medullary interstitium with its increasing concentration gradient. The binding of ADH to vasopressin V2 receptors upregulates the expression of water channels aquaporin 2. As the dilute filtrate delivered from the loop of Henle and distal convoluted tubule passes through the medullary interstitium, some water is reabsorbed via aquaporin 2, and the rest is excreted. In a high ADH state, more aquaporin 2 channels are expressed, more water is reabsorbed, and less is excreted. Unrestricted free water intake in high ADH states can easily lead to severe hypoosmolality and hyponatremia. Because of increased water reabsorption, the urine in high ADH state is expected to be concentrated with a high osmolality. So far, we've mentioned that renal water reabsorption requires ADH binding to vasopressin V2 receptors to increase aquaporin 2 expression. Mutations of V2 receptors or aquaporins can result in defective water reabsorption, thus excessive water excretion. The fourth factor that is needed for effective water reabsorption is a high medullary concentration gradient. Imagine a homogeneously dilute medullary interstitium. Even in the presence of a large number of aquaporins, there is no osmotic force for water reabsorption. In the presence of a low medullary concentration gradient, a great amount of water is excreted. Now that we've discussed the major factors required for optimal water reabsorption by the kidneys, let's see what can cause the kidneys to fail to reabsorb water. Excretion of high volumes of a dilute urine is referred to as aquaresis. Aquaresis may occur when there is no ADH due to central hypothalamic failure. There are non-functioning vasopressin V2 receptors. This may be due to mutation of the V2 receptors or the use of a class of drugs known as vasopressin receptor antagonists or VAPTANs. There are mutations of aquaporin too. There are problems with the maintenance of a strong medullary interstitial concentration gradient. Clinical examples include the use of loop diuretics, hypercalcemia, hypokalemia, malnutrition, or medullary ischemic injury. Conditions that can cause aquaresis are known collectively as diabetes insipidus, not to be confused with diabetes mellitus, which is a condition associated with problems with glucose metabolism. Central diabetes insipidus refers to aquaresis due to the lack of ADH. Nephrogenic diabetes insipidus refers to aquaresis due to the resistance of ADH at the kidneys. Any of reasons number 2 to 4 can give rise to nephrogenic diabetes insipidus. Imagine a patient who has a very dilute polyuria of unknown etiology. How can we tell if this patient has central versus nephrogenic diabetes insipidus? We have a diagnostic test called the water deprivation test. In this test, we first restrict water intake and monitor patients' effective plasma osmolarity. Simultaneously, we measure the patient's urine osmolality. For a normal patient, the urine osmolality gradually increases as the plasma osmolarity goes up with water deprivation. This is because as the plasma becomes more concentrated during water deprivation, ADH secretion increases to increase renal water reabsorption. In patients with partial central diabetes insipidus, meaning patients can still make some ADH but not enough for the body's need, or partial nephrogenic diabetes insipidus, meaning kidneys can partially respond to ADH, the urine can be partially but not maximally concentrated as seen in normal individuals. In patients with complete central or complete nephrogenic diabetes insipidus, the kidneys cannot reabsorb water at all, which means their urine cannot be concentrated at all. The urine osmolality will remain low despite having a high plasma osmolality. Once the plasma effective osmolarity reaches 295 or greater, we administer a small dose of DDAVP, which is a synthetic analog of ADH. Normal individuals who have no problem with ADH secretion will have no change in urine osmolality because they already have maximal ADH secretion with water deprivation. A little extra dose of DDAVP does not do anything extra for them. Patients who have partial or complete central diabetes insipidus will appropriately concentrate their urine and increase the urine osmolality with DDAVP administration. Patients with partial or complete nephrogenic diabetes insipidus, however, will also have resistance to DDAVP and will not be able to concentrate the urine. The urine osmolality in patients with either partial or complete nephrogenic diabetes insipidus remains unchanged with DDAVP administration because their problem is having resistance to ADH, not the lack of ADH. Finally, we move on to the topic of polyuria, a condition where there is large volume of urine output. Polyuria may be considered when patients produce a urine volume greater than 40 ml per kg body weight per day for adults. Polyuria may be diagnosed with a 24-hour urine collection where the total urine volume is measured. Polyuria may result due to excessive free water loss, known as aquaresis, or osmotic diuresis. As we've discussed, aquaresis may occur due to central diabetes insipidus, commonly referred to as central DI, or nephrogenic DI. Aquaresis may also occur when patients drink water excessively, referred to as polydipsia. In the case of polydipsia, polyuria has nothing to do with ADH or problems with the kidneys. Imagine an otherwise healthy individual with normal kidneys, normal ADH secretion, and normal plasma osmolarity, as evidenced by a normal plasma sodium concentration, who now decides to drink 10 gallons of water. What happens to ADH? Normally, ADH would be shut off to block renal water reabsorption. The kidneys will excrete as much water into the urine as possible. The individual will be producing high volume of a very dilute urine. In young individuals with good kidneys, the kidneys can dilute the urine down to an osmolality of 50 milliosmoles per kg. However, since the water intake exceeds the kidney capacity to excrete water, the retained water can lead to hypoosmolality as evidenced by hyponatremia. Moving on to solute or osmotic diuresis. How does osmotic diuresis occur? Imagine a urinary filtrate that is highly concentrated with solutes and whose tonicity is equal to or greater than that of the medullary interstitium. Water would remain in or move towards the side with higher tonicity, which is the urinary filtrate in this case, and gets excreted along with the solutes. This is referred to as solute or osmotic diuresis. Clinical examples of conditions and agents that can cause osmotic diuresis include hyperglycemia, seen in patients with poorly controlled diabetes mellitus, the infusion of hypertonic alimentation known as total parenteral nutrition, or commonly referred to as TPN, the infusion of the osmotic agent mannitol, or the excretion of myoglobin or hemoglobin from muscle or red blood cell breakdown respectively, or very high blood urea nitrogen seen during the recovery phase of acute kidney injury. At this time, you should be able to discuss how ADH receptor, and the medullary concentration gradient work together to reabsorb water in the kidneys, the difference between aquaresis and osmotic diuresis, and central versus nephrogenic diabetes insipidus, and diagnostic testing for diabetes insipidus. You should also be able to determine how water intake and/or defect in any of the factors involved in renal free water reabsorption can affect plasma osmolality and sodium concentration. The end.